It was a wonderful talk, and I really loved the idea of the headspace. As per the format of the session, we will have the question and answer at the end of the session. So please note down your questions because there are so many speakers and the particular question may be addressed to that particular speaker. So note down your question. So the next talk is the future of head and neck cancer imaging. We all understand the staging. We all understand the importance of staging, and there can't be a better speaker to speak on the staging of head and neck cancer than Dr. Jatin Shah himself. We all understand Dr. Jatin Shah. We know him well. He has been there in our lives as a head and neck student, now as a consultant, now as we grow in our career. So truly he is a living legend, and his contribution to head and neck staging in a personal capacity as a chair of the head and neck services at Memorial Sloan Kettering Cancer Center. I think he served in AJCC committee for several decades, I would say. UICC staging also, the TNM staging also, he served on the board. So Dr. Jatin Shah, it is truly a pleasure for us that now we are migrating for the conventional TNM staging to a newer model of staging. And perhaps I don't want to steal the thunder from your presentation, so I welcome you.
Thank you, Pankaj. So let me straightway go into why do we stage a tumor? The reason we stage a tumor is that you want to measure the volume and the extent of disease. You want to use the staging to plan selection of treatment. You also want to use the staging because patients will come and ask you, doctor, what stage is my cancer? So it is to assess prognosis. And finally, we use the staging as a measurement to compare outcomes in different geographic regions, among institutions, and more importantly, among various treatment modalities. The TNM system is nearly 80 years old. Pierre Denva introduced it in 1944, tumor node metastasis. It was a simple system. A stage 1 would be primary tumor, stage 2 would be lymph nodes, and stage 3 would be distant metastasis. That was the initial concept. It took nearly 10 years for the UICC to accept the TNM staging system, and the American Joint Committee 6 years later adopted the TNM staging system. And for the past now 30 years, the AJCC and UICC are working together. We now have a uniform, globally acceptable staging system. Up until 1980, there were two staging systems, UICC and AJCC, and there was a confusion. But since 1980, the two committees of UICC and the American Joint Committee are working together to develop a uniform staging system. Now in developing, devising, or organizing a staging system, 4 points must be considered. It should not be very complex. If it is too complex, nobody will use it. So it should be relatively simple. But it should be enough to discriminate various stages. For example, we have 4 stages of cancer. You cannot have 90% of cancers in stage 1 and stage 2, 3, and 4 in the remaining 10%. So theoretically, the 4 stages should be in each quartile of the domain of staging. So it should maintain discrimination between the 4 stages. It should be simple enough so that people will comply and use it. You can have a perfect system, but if nobody is using it, it is useless. And finally, rarities in events, observations, findings, which occur less than 5% of the times are not considered into the staging system. They are considered rare events and they do not enter into the staging system. I had the good fortune of serving the American Joint Committee for 20 years in revising the staging systems. So I have a little bit of a familiarity with the topic. How often do we revise the system? Too frequent revisions of the staging system should be avoided because we will not be able to generate any comparative data to show the outcomes of disease and therapy. So the minimum time interval for revision of a staging system should be at least 6 years, so that you have at least a 5-year period of observation of the previous revision to implement changes into the next revision. On the other hand, we need to introduce new discoveries and new knowledge that has to be incorporated in the revisions of the staging system to continuously improve it and make it more accurate. So it's a diverse, priorities. At one end, you want to maintain a high compliance, and therefore you want to keep it simple. And at the other end, you want to introduce new factors to make it more accurate and make it more more predictive. But then it becomes more complex, and therefore compliance will be less. So to develop a staging system, it is a compromise between the ideal and what is more practical. So this is the way the staging system evolved. In the 1940s and 50s, it was simple T&M. Then as the years went by, we introduced non-anatomic prognostic factors and started continuing recording of the other prognostic factors, which was parallel recording, not introduced into the staging system, but to gather data such that we can test that data retrospectively, validate it prospectively, and then introduce the new findings, new observations into the next revision of the staging system. Our ultimate goal is to move on to nomograms rather than a static staging system, and I will explain to you why. So in the last revision, 8th edition of this AJCC UICC staging system, there were two goals, two mandates given to us. That it must have global applicability. People in the villages of Africa should be able to use it, and not just in the high towers of MD Anderson Cancer Center or Memorial Sloan Kettering or University of Toronto. It should show incremental improvement over the previous system and maintaining harmony between the two agencies, AJCC and UICC. Again, even the revision is a compromise between a highly accurate but a complex system with low compliance or a simple high compliance system with a diminished capacity of predictive value. The 8th edition finally came into being in 2016, and it showed significant changes, and all of you are aware of it. It's now 8 years. It changed the staging system of the lymph nodes in the neck. I won't have time to go through all of these, but I will touch upon oral cavity and oropharynx. But there were changes in thyroid and skin and nasopharynx also. In the nodal staging, one observation was that extranodal extension was probably the most predictive factor prognosticating outcome, more so than the size of the lymph nodes or the number of lymph nodes or the laterality of lymph nodes. So simple extranodal extension, regardless of the size of the lymph node, upstages the tumor to an N3. You can have a 1 centimeter lymph node on one side, but if there is extranodal extension, it is N3. And that has been validated by retrospective data. In the staging of primary tumors, for example, in the oral cavity, we added the third dimension of the tumor, the depth of invasion, which is probably more accurate in predicting the risk of nodal metastasis and eventual outcome than the surface dimensions of the tumor. And finally, the new disease, HPV positive oropharyngeal carcinoma, a unique entity, had to have a separate staging system because it's a biologically different cancer. So here is a pictorial demonstration of the revision of the nodal staging system. The diagram on the lower right shows that extranodal extension, regardless of the size of the lymph node, will upstage it to N3. For primary tumors, the depth of invasion has been divided into 3 categories: less than 5 millimeters, 5 to 10 millimeters, and more than 10 millimeters. You are all well aware of this. And here now, for example, in tongue cancer, we not only measure the surface dimension, but we also measure the depth of the tumor to accurately T-stage the tumor. As I mentioned, HPV positive disease in the oropharynx is a biologically different entity, usually affects younger patients, healthier people, non-smokers, and it is diametrically different because it is very responsive to treatment. And I didn't say very responsive to radiation or chemotherapy, to any treatment. HPV positive oropharynx cancer responds to surgery, to radiation, to chemotherapy, any treatment, and it gives you an excellent outcome. The natural history is very different than tobacco-induced cancers, which we are more used to. Yes, I see the time, no problem. This is very helpful, and I will stay in time. So there is a separate staging system for HPV positive cancer, where the T category remains the same by dimension, but in end staging there is a major change, and that is simply the size of the lymph node. Any number of lymph nodes less than 6 centimeters on the same side of the neck will be N1. Contralateral or bilateral nodes would be N2, and any lymph node bigger than 6 centimeters would be N3. But the question we need to ask, and here is where I will spend the rest of my time, is the current system adequate? The short answer is no, it's not. Is it workable? Yes, it works for us for now, but there are problems because it considers only the gross tumor factors. It does not include pathological features of the tumor, such as lymphovascular invasion, perineural invasion, tumor differentiation. It does not include functional status of the anatomy involved. For example, movement of the tongue. If the tongue is paralyzed due to the volume of the tumor, that is not considered into the staging system. It does not include patient factors. Patient is old, has comorbidities, is a smoker, is alcoholic, has cardiac disease, has pulmonary disease. All of these impact upon outcome, but they are not included into the staging system. Besides, the TNM staging system is static. You see a patient with stage 3 tongue cancer today, and that enters into the record of the patient. 5 years from now, the patient is cured of cancer, comes for a follow-up, the record will still show patient has stage 3 cancer. He doesn't have the cancer. The cancer was 5 years ago. Why do we label the staging for the patient's life? It must be dynamic. As the disease moves or the patient's life moves, the staging must move with the patient. So you can't call that patient having stage 3 tongue cancer, which was treated and cured 5 years ago. And finally, it doesn't include response to therapy. There are patients who respond to induction chemotherapy, for example, whose tumor will disappear, and they will have a great outcome. In contrast, there are patients who don't respond to induction therapy, and they will do poorly, but they have the same staging system. That is not introduced. So these are the deficiencies of the current staging system. So in future, we want to incorporate the TNM staging system, but also include other parameters such as the histomorphological features, molecular markers, non-anatomic prognostic factors, socioeconomic status, lifestyle and comorbidities, as well as response to therapy, and make it a dynamic, personalized prognostic nomogram. So the nomogram will move with you as your life moves with you. It should not be a static staging system. A modern medical nomogram is a statistical prognostic model that generates a probability of clinical event of a particular individual based on their specific characteristics. It can be shown graphically on a printed graph, or you can have it on your smartphone with an app. So you simply enter the parameters and you have the patient's dynamic staging system on that day at that time for that patient. And that is the ultimate goal. So here is a graphic presentation of how a nomogram is created. You take the important parameters that you want to include in the diagram. For example, in this patient, patient's age, primary site, status of the lymph nodes, history of tobacco consumption, and so on and so forth. Each parameter has given a point score based on the available data, and you draw a diagram. For example, here is a patient with a 3 centimeter tumor represented by the red line, giving him a score of 70 points. Primary site is on the tongue, which gives him a score of yellow line, which is 38. Then if there is bone invasion, there is a, which all of these adds up to a point score of 138, which is the blue line at the bottom, and that tells you the patient's anticipated outcome at 5 years. And that is how you create an individual personalized nomogram. Now, the advantages of the nomogram are that it has the ability to estimate the individual risk, it is user-friendly, it incorporates continuous variables, and is better than the clinician's judgment. Number of examples of nomograms exist in the literature. They are there for estimating the risk of nodal metastasis, the outcomes of treatment, the outcomes of quality of life. So you can create a nomogram with any goal or endpoint that you want to create. But take, for example, the current staging system. Here are 3 patients with oral cancer. By current staging system, all of them have stage 3 oral cancer. All of them have T2N1 oral cancer. The first patient, case 1, is a 60-year-old male who is a smoker with comorbidities. Case 2 is a young female, non-smoker, no comorbidities. And third is a 40-year-old male with the upper alveolus tumors and a 2 centimeter lymph node. And by current staging system, their outcome would be all about anticipated 36% 5-year survival for stage 3 oral cancer. But we have not considered host factors, tumor factors, and treatment factors into this staging system. We also know that within each stage, there is great variance. Stage 3 doesn't mean everybody is going to have 36% outcome. There are stage 3 patients who will have a 80% cure rate, and there are stage 3 patients who will die within 2 years. So there is a great variability within each staging system. So now if we go back to the same 3 patients and include their parameters, let's take the first patient, the older patient who is a smoker and with comorbidities, and put them on the nomogram, his survival probability is only 0.3%. And if you use the nomograms like that for these 3 patients, the anticipated outcome is going to be different. 30% probability for the first patient, 65% probability for the second patient, and 80% survival probability for the third patient. They all have stage 3 cancer based on current staging system, but on prognostic nomograms, their outcomes are different. So then the question is, are the prognostic nomograms perfect? Well, the short answer is no, they are not perfect either. It's an improvement over the TNM staging system, but it also assesses prognosis at the time of initial diagnosis. As time passes by, the patient gets older, other comorbidities appear, which will also impact upon outcome. As the time goes by and the tumor does not recur, the probability of death from cancer goes down, but the probability of death from old age will start rising. So we need a dynamic nomogram which moves with the patient. So here is the same patient. His pre-op probability of survival is 55%. He undergoes surgery. You add the pathological parameters and the survival probability drops down to 52%. 1 year goes by, everything is good, but he has become 1 year older, so his probability drops down to 47%. 3 years after the surgery, he develops recurrence, lung metastasis, brain metastasis, and starts on chemotherapy. His probability drops down to 38%. 7 years out, there is progression of disease. So his probability drops down to 20%, and eventually the patient dies. So we need a dynamic nomogram as the patient progresses through his life. And what happened in this patient? Surgery, post-op radiation therapy, distant metastasis, and dead with disease. The prognosis changes through these events in the patient's life. And it changed because of the occurrence of these events, starting from 52% probability to 20% prior to death. So when the patient comes and asks you, doc, what are my chances? You open your iPhone, punch in the parameters, and be honest with the patient. This is where you are today. In contrast, here is a patient who did not have recurrence of cancer and continues to live, but her survival probability drops from 86 to 69% because she got 8 years older. Other comorbidities came in. Cancer didn't come back, but the probability of death will increase as the years go by. So the goal is we are going to have all of this on an app on the iPhone. You simply enter the parameters and you will have the answer. So in conclusion, staging is a continuously evolving and a dynamic process incorporating new and valid information to improve accuracy and predictive power throughout the patient's life. And that is the ultimate goal. Thank you. I'm 4 seconds before time.